Good afternoon, everyone. Welcome to our latest Affordable Care Act, ACA webinar, kind of a briefing on the Affordable Care Act as we know it as of today. This is an ever-changing topic, we know, and we know that you all have a lot of confidence in the Kempton Group to keep you all abreast of the things that you need to be thinking about as it pertains to your plan and how you run your business. This is actually the second webinar we've done today. We actually did it for another group of employers this morning. And so Maria and I are a little bit almost maybe semi-punch drunk after that one, but it went very, very well. I'm Jay Kempton. Most of you all know me as I know you all. Also, Maria Robles Meyers is here with me. She works very, very closely with the Kempton Group and with some of you all within your employer and your employer plan. Maria has been speaking quite a bit over the last 2 or 3 years on the Affordable Care Act, and we feel very fortunate to have her working hand in hand with the Kempton Group. She's also recently was invited to speak at the Self-Insurance Institute of America late last year, where she also did a briefing on the Affordable Care Act to the self-insurance industry. Now, with all that being said, I was going to go quickly over the agenda. We've all been hearing about the Affordable Care Act now for a little over 3 years, and it's been just a lot of puzzle pieces for us. And I mean, this is our business, but lots of different little pieces, and it's been a long time coming for those puzzle pieces to start to fit together for us to where we could actually describe the picture and then be able to describe the pieces individually that made up the picture. Marie and I kind of view that as kind of good news, bad news, because if this stuff is actually starting to make sense to us, that is a little concerning, or maybe we're just desensitized to it. But we kind of laid out the webinar in a very logical grouping that I think it's important for you all to kind of have the webinar framed. The 3 topics that we're going to talk about is the Affordable Care Act and just the benefit changes that are contained under the Affordable Care Act. Now, a lot of you all have sat with me and your account manager as we've kind of walked you through these benefit changes. Some of them are going to be old hat. Some of them are things that maybe have not happened yet, maybe haven't happened for your plan yet, but we want to bring them to your attention. The other 2 pieces, though, are the taxes and the reporting. Now, the taxes, also known as fees or penalties, or Maria's favorite,
assessable amounts.
Assessable amounts. We were introduced to that concept in Washington, D.C. Last month. But the penalties, now there's penalties, there's shared responsibility, there's assessable amounts that affect individuals. It's just individual citizens. So we're going to talk a little bit about the individual responsibility and how it kind of fits into your business. We're also going to talk about the employer responsibility. And then finally, the plan's responsibility to hopefully stay outside of the penalty box or into any type of fine situation. And then lastly, we're going to talk about reporting. There is reporting mechanisms for the individual, for the employer, and for the plan to essentially be able to prove that you are doing what you're supposed to do under the Affordable Care Act that keeps you out of the penalty mode. And so we're going to talk a little bit about the 3 reporting categories and how they apply to the particular tax or penalty scenarios for the individual, employer, and the plan. Now, for those of us that have been with me and Maria before, you know Maria is the brains behind our compliance team. So I'm going to turn over the majority of the presentation to Maria, but I'm going to be here kind of giving color commentary and also if I hear her kind of go attorney on us, maybe bring it down to where I know we can all understand it. But with that being said, Maria, go ahead and take us from here.
Okay. First thing I'm going to tell you is please keep in mind that this law, to me, sometimes I call it Obamacare, sometimes it's PPACA. In the marketplace, you hear it as ACA. It's all one and the same. It is evolving. And even though we have components of it that have been clarified or explained through regulations, there are changes that are constantly being made, and we're seeing more and more of them this year than I've seen in a while. I'm anticipating more changes, so I want you to keep in mind that what we are saying is what it is as of today, and some of these things are possibly or likely could change in the next few months as we start gearing up for 2015. And I don't mean that to say it in any sarcastic way. The regulations are coming out in volumes. This March and April, there were at least 5 sets of regulations, all of which were at least 100 pages in length. And they're explaining sometimes some simple concepts that you think were well defined, and now there's more to it. So it is a moving, volatile kind of deal, and I want to make sure that you all understand that and keep that in mind. That being said, there are a couple of things in the benefit arena in terms of the ACA that need to be addressed. One is, I want you to see where it says ACA plan years beginning in 2014. Some of you have calendar year plans and the changes would have been effective January 1. Some of you have fiscal year plans that actually start during the year, and some of the requirements then kick in on the first day of your plan year. So when you hear me talking about 2014 or things that have to be done, we're talking about whatever your first day of your plan year is, not just January 1 of 2014. Children. The provisions that the health plans provide health coverage for children up to age 26 has been out there for a while. If you're grandfathered, you may have had a condition on them saying that they could stay on yours unless they had coverage through their employer's plan. Effective in the plan years beginning in 2014, the condition has to go away, and so the plans will now be covering children up to age 26. And actually, kind of interestingly, recently there was clarification from the IRS that said up to age 26 means the last day of the plan, the last day of the month in which they attain age 26. So it's not the day that they attain it. They view it as through the end of the month in which they attain age 26. But that's one of the things that's here to stay. I don't envision that going away by any legislation or change. I think that's here. Pre-existing conditions are probably one of the bigger ones that really are impacting plans this year. The pre-existing condition limitation basically was the provision that allowed a plan to not pay for certain benefits if the individual had a condition that existed prior to them being covered under the plan or prior to them being eligible to be covered under the plan, because the waiting period didn't matter. But they were designed so that if someone had not had coverage, the pre-existing conditions would come into play for a period of time, and the plan would not start to pay expenses until after those conditions were met. For those of you that remember the HIPAA creditable coverage rules, the provisions that came into play back in '96 under the Clinton administration were designed to ensure that individuals who had continuous coverage wouldn't be penalized when they moved from one plan to another, and so the creditable coverage concept came into play, being that if you were covered and you demonstrated through a certificate of creditable coverage that you were covered, then you were not required, the plan was not allowed to provide for a pre-existing condition, and the employee was not required to have to wait until any coverage began. With the pre-existing condition completely being done away with, obviously the creditable coverage is no longer a viable concept. It doesn't really matter anymore. It is really a cost feature in the plans that I think will increase the cost of plans because there is no limitation on anything that existed prior to the time. So you can get someone who comes onto your plan who's under treatment somewhere else and they're on, no limitations for them.
Of course, the theory is that they can come onto your plan with no pre-existing just as easily as they can go onto somebody else's plan with no pre-existing.
Absolutely.
But we'll see.
But that, that's a concept that is, I think, going to be eliminated. I don't see that as anything that's going to change in the future either. I think that's here to stay. The third item is the annual limits. Some plans still had like a $2 million limit on benefits for the plan years beginning in 2014. It is unlimited. You cannot have any of those limits. You can't have a lifetime limit. You can't have an annual limit overall. And as we'll get into some of the other sections when we talk about the essential health benefits that your plan may offer, you can't offer annual limits on those either. So those three conditions right there pretty much eliminate a lot of the cost containment features that were built into plans. And I think as the years evolve, I think we're going to see the repercussions from that in terms of the increased cost that plants will be incurring. The fourth item is one that I'm struggling with because the law says that you cannot have a waiting period that exceeds 90 days. And that provision of the statute is actually written in terms of days, not months. So 90 days did not translate into 3 months. So we've been operating under the premise that 90 days meant 90 days. About 3 weeks ago, Jay and I were in Washington, D.C. at a conference, and it was an interesting presentation because one of the things that they've come up with is they've modified the measurement period, if you would, for when this 90 days comes into play. And what they've created is an opportunity for employers to delay the starting point at which you start counting the 90 days. And what they call this is a bona fide documented orientation period. The regulations use that term, and that is all they do. They do not define it. There's no real guidance on it other than a couple of little things that they specifically said. One is it can't be more than 30 days. And the second is that it cannot be a subterfuge for eliminating the 90 days. So I'm struggling with how to define that, but it certainly is an opportunity for employers to really work with it if we can figure out what a bona fide documented orientation period means, and it's actually documented as that, and it is applied to everybody in a non-discriminatory manner so that instead of counting the 90 days from the date that they initially become eligible or meet conditions of eligibility, the waiting period to actually be covered is going to start not on the date that they meet that condition, but whatever the end of the period of this bona fide provision is. So for some of you that have policies in place where you have some kind of orientation period or something that you actually apply across the board to people, where you, in my head, I look at it as you really treat them as an absolute test basis. This may be an opportunity to really evaluate whether you use that in terms of your plan. I know when the 90-day period first came out, we preached that for the most part, waiting periods shouldn't be more than 60 days, so that most plans start coverage on the first day of the month following the date that they meet the conditions. If you had 90 days, it was easy to bust the 90-day limit when it was the first day of the month after they met that. But with a waiting period, there's an opportunity to possibly go back to a 90-day, but it has to be defined differently.
It's in two categories now, regulatory-wise.
It's in two components. This would need to be something that is in the plan document. You would not want to just apply it, have a 90-day wait in the plan document and then have something on the side that said, here's my bona fide period. I think the plan documents are going to have to use that information and build it into the plan so that everybody's on board as to when you're actually going to start counting 90. It's no longer going to be the first day of hire.
But your account manager will attempt to keep you abreast of if there's any additional regulations or definitions about this bona fide documented orientation period. So I think the recommendation is more of a cautionary tone. I think a lot of plants have gone ahead and moved their waiting period down to 60. If you were going to go ahead and utilize the 30-day prior to the 90-day or the 60-day waiting period, that I probably want to be careful, just because at some point you may be asked to document or show that you have a bona fide documented orientation period that you used as the prior to the waiting period. And if we don't have a definition for that right now, we don't really know how to advise you to document that.
And I think, from the regulatory bodies, the IRS, DOL, and HHS, I think they purposefully did not define what that means because they're waiting to see what happens in the industry in terms of how it's implemented and what creative approaches people come up with. And I think once that starts to kind of become clearer, my expectation is that they will come out with some definition of what this bona fide documented orientation period really means and putting conditions on what you can and can't do with it. So I think there's more to come on that. On the last item is the flexible spending accounts. For those of you that have flexible spending accounts, I think most of you are aware of the two options that became available last year. most FSAs have had a grace period that allowed individuals to provide documentation for expenses that were incurred before the end of the plan year and be reimbursed for them after the end of the year. So for example, if you have a calendar year plan, employees were allowed to provide their invoices up through, in January or February. And if it was for an expense that was incurred in the prior calendar year, then it would be covered using the prior calendar year's amounts. And then if they didn't use it all, then it was lost, it was forfeited. Last year, the IRS came out with the concept of a carryover. It is a concept whereby in lieu of having to spend your money, you can keep up to $500 and carry that over. The 500 is a cap. It's a maximum that they've put out there. It can be less if you choose to have less. But the important thing is there's two components to it. One is it's an either or. You either have a grace period or you have a carryover period. You cannot have both. The second part of it is it has to be documented in your plan. If you don't have one or the other, or you want to change from one to the other, that is doable, but it is really important that that change be documented and written into your plan documents this year in order to be effective in 2015. If you do end up using a carryover, the one thing that's out there that's kind of unusual and unique is the carryover, the FSA is considered by the regulators as a health plan, and therefore an individual that has a $500 carryover to apply into the next year is considered to be covered in an employer health plan, and it in most cases will prevent them from getting on the exchange and getting subsidies or assistance with their out-of-pockets. And so what they have come up with is an individual that has a carryover has to be offered the right to waive the right to receive the benefit of that carryover in order to be able to go on the exchanges and not have any employer coverage. And that's an option that is, it has to be offered to the employee. It's not an option that the employer can say we're not going to do it. So as the renewal on the calendar year plans, as the renewal comes up at the end of the year, it's important that people have the ability to say, I would have had a carryover, but I'm waiving it. And once they waive it, it's gone, it's forfeited from that point. But it has to be done in writing before the end of your plan year. That's the biggest chunk of the ACA in terms of those benefits. The other component that has come into play that is impacting plans and the cost of plans and how they're administered is this concept of a limitation on out-of-pocket amounts. I distinguish it by saying there's a plan out-of-pocket and there's a federal out-of-pocket. The PPACA out-of-pocket amount says that if you have single-only coverage, in theory, you're not supposed to be out more money than the $6,350 this year. These numbers will be adjusted, so for 2015, the amount has already been released, and it's $6,750. For family, it's $12,700 or $13,500. And these amounts they include the deductibles, they include the plan out-of-pocket amounts, and they include any copay. So if you have like a separate surgery copay or a separate ER copay, those amounts are supposed to be aggregated in a way that when they are totaled, the individual is not out more than that $6,350 at the individual, one single coverage only. That concept applies in network only. So if there are expenses or items that are out of network or things that are disallowed that the employee has to pay for, those don't count to the $6,350 or the dollars. When I use $6,350, I mean any of them as it would be applicable. But those things that aren't covered, the things that are out of network, don't impact that at all. So you're counting only the in-network amounts that the individual is actually outlaying some funds for. In 2015, the federal out-of-pocket limitation does not count any copays that are incurred with the prescription drugs. And those generally are, most of the employers that have a separate prescription drug program will have a copay for specific kinds of drugs, whether it's generic or a brand name or, mail order stuff where you have volume prescriptions provided. And those in 2015 don't count, but they don't, in 2014 they don't count. In 2015, they do have to be included in that aggregating number. So the $6,750 in 2015 will include the out-of-pocket for prescription drugs. The difficulty I think that comes into play is from a perception in the marketplace when people hear about this out-of-pocket limitation, they sometimes, I think, confuse a plan out-of-pocket limitation with what I call the federal limitation. So if you have a plan that is a very generous plan, which some of you guys have, You may have a $500 deductible with a $2,000 plan out of pocket, which means you're $2,500 out. So between the $2,500 and the $6,350, there's a lot of room for any of the copays that the employee is paying. Employees tend to think that when they meet that plan out of pocket, they're done, and that's not how it works.
We're a little concerned that when this starts really getting into the public's consciousness and you start seeing this stuff on the Today Show and kind of in the mainstream media outlets, they're gonna some of it's gonna be lost in translation. A majority of our clients have out-of-pocket maximums that are under the $6,350 and definitely under the $12,700 for family. So I think people are going to kind of go off half-cocked. They're going to maybe understand that there's this new $6,350 and $12,700 limitation on the out-of-pocket. I think that's going to be lost in translation. They're going to think, well, once they've met their plans out-of-pocket, which may be less than the $6,350, and then they go to the drugstore the next day and their copay is going ahead and applying, and they continue to be out of pocket their copays and things of that nature, they're going to think that your plan's somehow out of compliance because they heard that once their out of pocket was met, prescriptions and it's met for everything, drugs and office visits and everything else. And so there is a little bit of maybe a gap that some of our employees may not be aware of. So we want to make sure that you all were kind of in on that joke, and when that does happen, that you can remind your employees that, you know, we have an out-of-pocket max at the plan level that's under the federal, so you're going to continue to meet some of those out-of-pockets until you reach the $6,350 or the $6,750 in 2015.
Yep. I think from a going forward kind of perspective, this is probably going to be one of those provisions that really does impact the plan the most, because it eliminates a lot of the ability to really steer people in one direction or another. Once they get to whatever the federal limitation is going to be, they won't have any nickel in the game, and so it will be much easier for people to say, I can do whatever I want because it doesn't matter, the plan's going to pay for it. And I think, you know, we're struggling with how to work with that and how to define it within plan parameters so that you guys can continue to have some ability to have some cost containment features that don't just sidetrack you completely once they get to the $6,350.
Yeah, and that is a great point. I think I've talked to some of you all about that, but that's one of the things that is concerning for me is, you know, when somebody does meet their out-of-pocket max, for instance, the federal out-of-pocket max, and everything is free. You know, premier providers, for instance, you know, we're waiving deductibles and copays and coinsurance. If somebody has met their out-of-pocket max, then all of a sudden all in-network providers, premier, not premier, you know, efficient providers, inefficient providers, as long as they're in network, it's going to be free. And so it's going to be more difficult for us to be able to incentivize that employee to buy better, buy more efficiently. Some of you all have already gone to Kempton Premier Provider Mandatory. We look at that as a potential strategy to get around this, because essentially for those particular procedures, what we're saying is that there is a very narrow network. There are only certain providers that are considered in network on a procedure by procedure basis. You all that have adopted that, you know, that is not smooth as silk. There are some, you know, there's more heavy lifting from an HR perspective and from Kempton's perspective. But unfortunately, as costs continue to march up and we're having to deal with some of these out-of-pocket maxes that are federally imposed, we as a team may have to start considering more seriously the idea of limiting what's in network and what's out of network. Because again, in network is subject to these maximums, out of network is not. Okay.
The second component of what we want to talk about today are the taxes. There's a lot of different names for these things. To me, they're taxes. There's several layers of who the tax applies to. So the first one we're going to talk about is the individual responsibility, which in the media is called the individual mandate. That is in effect for 2014. There are a lot of different reasons why someone can get an exemption or not be subjected to it in 2016. And if you've been watching the news, you know that as the exchanges opened up, and the rollout was less than perfect, that the extended time periods for enrollment kept being lengthened. When they even set the final hard line of March 31, they said, well, if you were in line on March 31, we'll let you go until April 15. In some of the state exchanges, they actually let them go through April 30th. So the actual enrollment period was way off from what they anticipated, and therefore they've expanded these hardship situations. The individual mandate is intended to be the component that is designed to have individuals, and by individuals I mean actual employees, not employers, but the actual employee, participate in the process of sharing the cost of health care. And the concept is, if everybody is in the plans, if everybody is covered, whether it be individual policies or under group health plans, and everybody's participating with the premium payments or the cost sharing of the plans, then the total cost will come down. In the marketplace, the push in the very last part of March was geared at the young individuals because the younger people were not signing up. The reason they don't sign up is because they tend to be the healthiest people who don't think they need the health care coverage. And when they don't sign up, what happens to them is the money that they put in, which they're not going to get back because they don't use the system, isn't then available to pay for the health care of those who are older and sicker, and therefore the adverse selection in the exchanges gets even higher. So this tax was really imposed to bring out the concept that everybody in the United States is going to have health care coverage under one form or another. And if you as an individual choose not to have it, then you're going to have a tax. Now, the tax amounts you can see, in 2014, they're $95 per adult, $47.50 for a child, with a maximum of $285 for the family, or 1% of income, which is actually adjusted gross income. I mean, even 1% of $100,000 is $1,000. If you're looking at, I'll pay $1,000 versus paying $1,500 or $15,000 for health care, if your dollars and cents weigh in, it's a deal. It's worth paying $1,000. It's not a big deal. The numbers are intended to go higher in 2015 and 16 so that it is encouraging people to make the decision to get health care coverage. This is going to be reported on the individual's Form 1040. The IRS has already indicated that it will be on the form. There will be a box where you're going to have to check whether you had health coverage, whether your spouse had health coverage, whether the dependents you're claiming had health coverage. And if they didn't, then I think the forms are going to automatically start generating these taxable amounts that you're going to be paying. The interesting thing about the individual mandate, which we have talked about before, is that there is no mechanism for collecting them. The only way the IRS really has the ability to collect this is if there is an overpayment and you're due a refund. They don't have the ability to just go out there and assess or levy or do any of the normal collection things that the IRS does so very well. So it is going to be interesting to see whether or not you get through this. In terms of the hardship exemptions are extraordinary, and the list has grown. I'll give you an example of the things that are out there. If you were uninsured for less than 3 months of the year, then it doesn't count. I believe that they said that if you were trying to get coverage on the exchanges and you didn't get it until the end of the March period, that doesn't count either. These taxes are imposed based on whether you have coverage on a month-by-month basis, so it's kind of an interesting scenario when they start waiving the time periods. But they have specifically excluded members of federally recognized Indian tribes, members of healthcare sharing ministries, or members of religious sects that have a religious objection to healthcare, and they include objecting to the Social Security Medicare thing. If you're in jail, you actually don't have to pay the penalty, which I think is kind of interesting. If you are not lawfully present in the United States, you don't have to pay it either. But the additional exemptions are, I'll just read you a few. If you were homeless, if you were evicted in the past 6 months, or you were facing eviction, if you got a shut-off notice from a utility company, that's a reason to get an exemption, a hardship exemption, and not be subject to these penalties. If you experience domestic violence, if you have a death close to your family, if you filed for bankruptcy, if you had medical expenses that you couldn't pay in the last 24 months, and the list is just kind of growing. So the more exemptions they have, the more people are out of this element, which from an overall big picture is really kind of an interesting fact, because if you're not going to get the money...
It's almost like the eligibility or criteria to belong to a credit union. It kind of starts looking like
it's very
almost
expensive.
Anybody.
Yeah, and I think it's going to continue to be expanded as other people find reasons why they shouldn't be subjected to it. But the concept is that when you have this shared responsibility, the first level we're talking about is individuals have to pay into it if they don't have health care. Employers are going to have to pay into it if they don't offer coverage. And so when you start looking at these components, the revenue features of this statute are being slowly whittled away, in that they're eliminating the people that are going to be paying these amounts, which is the revenue source that they were going to have to pay for it. But that is here, and that is effective in 2014. The second layer is the employer layer. At the employer layer, there are a couple of elements that I want to make sure you're aware of, and I want to kind of hit a little bit about them in terms of who's responsible for them. The medical device tax is at 2.3% surcharge on medical devices. That is currently in effect. They are collecting it. There are bills that have gone through at least one of the two houses, the House, not the Senate, trying to eliminate it, but they have not quite made it through. There's a lot of opposition to that. Right now, it's the plan. It's an additional cost of benefits when you have a medical device. It's being
Just
paid.
in your claims.
It's an additional cost, yeah. The second part is the employer plan taxes that are paid by the employer. And these were intended originally to kind of fill the gap, and so they're not going on forever and ever. They're intended to be shorter term. The HIT tax is the health insurance tax, which generally it doesn't impact the self-funded market. It impacts the insurance plans. And it was a way for them to have to pay a penalty so that there is revenue to offset the adverse selection that is anticipated from these carriers having people sign up for benefits that are sick. So that one doesn't really impact you guys much at all. The second one, some of you may be familiar with, or you should all be familiar with. Some of you may have already paid it. It's the PCORI tax, which is the Patient-Centered Outcome Research Institute tax. And it is a deal that is in play for 6 years. I believe it goes away in 2018. And it is designed to be a tax that was a per belly button. It's not an employee per employee tax. It's a per belly button tax. It is paid by the employer, and it is assessed against the employer, not the plan. The reporting for it is on the strangest of all forms. It's an IRS form called Form 720, which is an excise tax form that has surcharge on fuels and things that most of us don't do unless you're in those industries. The PCORI Institute is designed to, strange as it sounds, it really is designed to be the place where they will define what medical procedures are really the recommended procedures, because they are outcome-based procedures. So if you are a very, very sick person and you need a hip replacement because you need a hip replacement and you're already sick and you've got cancer, the outcome of getting a hip replacement when you've got cancer probably isn't going to do much for your life on an ongoing basis. And so there, I think the outcome is going to be that's just flat out not cost efficient. This is really an element of what they used to call, or at least in the initial debates, what do they call it?
Sarah Palin called it the death panels.
The death panels. Kind of like what you're seeing with the VA stories right now, where they're kind of rationing healthcare.
It's the rationing mechanism and research institute that's going to make rationing recommendations.
It's going to make rationing recommendations. The way it's funded is with $1 per belly button in year 1, $2 per belly button in year 2, and it applies to all health plans, whether you're self-funded or fully insured, doesn't matter. It doesn't apply to your individually accepted plans like vision or dental that are treated as an accepted plan, but the health plans are all subject to it. They are filed, the return is filed only in the second quarter. I looked as of this morning, and the IRS has not released the revised Form 720 yet. It's due by, I believe it's the end of July, which is when the second quarter federal excise tax forms are due. So this year, everybody will have to file it. In 2013, only the plans that ended between October and December filed it. If you filed in 2013, you would have paid $1 per belly button. You're going to pay $2 this year. If it's the first time you're filing, it'll be a $1 fee, and then $2 the next year. But I haven't seen the forms yet to be able to make sure that people know where they are and how to get them done. The third tax is that infamous reinsurance tax. It is a 3-year tax, and it is the one that is per belly button. You've seen it as either $63 per belly button, To me, a member is a belly button. I count individuals who are covered, whether they're employees, dependents, doesn't matter, they're a belly button. So each one pays the $63 or the $525, if some of you may have heard $525 a month. And I wanted to put the numbers in there so you get a sense of what they're doing with it. By statute, the law includes a definition that says that in 2014, HHS will collect $10 billion, which is going to be used for the reinsurance allocations, and then the $2 billion at the bottom, which is just to the general treasury, goes back to general pot, and then the $245 million estimated cost for what it costs them to administer the collection of this $12 billion. Those are actually a tax that's imposed on the plan, not the employer, so that can be paid by the plan. If you have a trust and you are paying your benefits through a trust, you probably have a VEBA, the Voluntary Employee Benefit Association, which is a tax-exempt trust that is used. It can be paid out of that. The PCORI can't be paid out of that, but the reinsurance tax can be paid out of those trusts. If you're paying it out of general assets, it doesn't matter. It's the same pot of money that you're paying it from. That tax is being used, and the reason that it's 3 years only and not ongoing is because the monies generated from that are going to be collected from all health plans, and then HHS will redistribute them to the insurance companies that offer individual policies on the exchanges or the marketplaces in order to help them offset the adverse effect of the people that are enrolled. So basically, you're paying part of the cost of the exchanges.
Right. The irony never stops. On PCORI, for those of you all that paid PCORI last year, as you know, the Kempton Group, we did provide the necessary counts for you all to be able to calculate that. We will continue to do that. So you can just ask your account manager when you're needing those counts, and we can supply those to you.
And the count for the reinsurance tax is computed the same way.
Introducing you all to some terms before we completely get into the weeds in the future slides. This is probably old hat to a lot of you all, but we wanted to make sure that we kind of re-emphasize some terminology because there's a lot of people that get confused when we field questions. There are folks that just get the nomenclature goofed up, and it's not that it's very straightforward. It's quite the opposite. But some of the requirements of exchange plans, which is not you, those benefits that are required to be offered on the exchanges are known as minimum essential benefits. Not to be confused with the requirements for self-insured plans, which are minimum essential coverage. To make matters worse, over on the exchange plans, when you hear those, the conversation about exchange plans in the media, they will use the term minimum essential benefits and essential health benefits interchangeably. And a lot of times they will say that all plans have to offer essential health benefits, which is not completely true. But again, minimum essential benefits and essential health benefits are interchangeable. One of them is actually a term that was just made up by the news media. Helpful. And then over on the requirements for the self-funded plans, there is the requirement to provide minimum essential coverage, which for those of you all that we've had a conversation about that already, that is essentially just the preventative care only. And then you also, all self-funded plans to stay out of the penalty box are also required to offer coverage that meets a minimum value and also minimum affordability levels. Anything I need to add on that?
Just to kind of put this in perspective, the concept that everybody's going to share in the cost of healthcare in the United States is broken out into the components. We talked about the individual mandate, which is individuals' responsibility for what they have to pay. This part of it is the responsibility for employers to offer the health benefits, or if you don't offer what is considered an appropriate health benefit, then the employer is subject to the penalties, and those penalties then are designed to offset the cost of healthcare because you didn't put your share into the pot. So it's real important that you realize that for the self-funded plans, the whole concept of having the minimum essential coverage with minimum value and affordable coverage are two elements that are designed specifically to ensure that employers are not subjected to the penalties that you will pay if you're not complying with it.
It's kind of a multi-step, multi-level test, and we're going to ready to walk you all through that right now, but we wanted to kind of get our vocabulary straight, hopefully.
Okay. Exchange plans, marketplaces, they're all the same thing. It's the statute calls them exchanges, the media calls them marketplaces, but they're the same thing. They currently offer individual policies, they're health insurance policies, but only to individuals. These are the ones that are on the exchanges where people are signing up to get. These are the ones where people are getting the subsidies in terms of helping to pay the premium, in some cases helping to offset their out-of-pocket expenses. All of the individual policies that are on the exchanges or the marketplaces are required to offer this minimum essential benefit. The minimum essential benefit is really a defined level of benefits that they actually have to provide. So they can't define how much they're charging for it yet, but they can tell them what they have to put in them. And the reason that this is important to you is because the exchange plans are required to have minimum essential benefits. Self-funded plans don't have to include all of the minimum essential benefits. And I know this is an area where we've had some questions, and so I want to make sure that you're understanding what this is so that it's in place, in a constructive place in terms of when you're looking at your health plans as self-funded plans and what this means. There are basically 10 areas, and those are listed in the blue box under, the ambulatory hospitalization lab and all those things. Those are the base level of areas of coverage that the exchange plans must have. They define the content of each one of those based on what the state's benchmark is. In Oklahoma, as in most states, the benchmark is the Blue Cross Blue Shield plan, or what was in effect prior to the Obamacare law coming into play. And that's the level of benefits that they've got to have. Self-funded plans are not required to include all of those essential health benefit categories. And so in some of our discussions in the past, I know that some of the issues that have come up have been specifically like with the pediatric services, the very last one, dental and vision, where under the essential health benefits, they have to provide no-cost pediatric services for dental and vision care, which historically have never been included in most medical plans. Self-funded plans that don't include pediatric services, the free dental, free vision services, are fine. You're not required to include that.
Under your medical plan.
Under the medical plan. The medical plan does not have to provide the free, no-cost sharing pediatric services. And pediatric in this level is not like a child, it's only up to age 19. That area, the dental and vision, probably has raised the most concern because employers think that as a self-funded plan, they've got to include all of those 10 categories. And that is not the case. The exchange plans have to include those categories. The self-funded plans can include them, and there's a reason that if you do include them, you can't have an annual limit on it, but you don't have to have all 10 categories. And so in many of the plans, the pediatric services, the free pediatric dental and vision stuff has not been included in your self-funded plans because you're not required to provide it. One thing that's out there, and I don't understand how it works, to be really honest with you, is this concept that when the exchanges rolled out and it became evident that plans were being canceled and that the plans that people had were a lot less expensive than what was on the exchanges, and the statements kept coming back, if you have your plan, you can keep it. The administration said, well, we're going to keep our word. Insurance companies, go back and give them the plan that you canceled. And they've gotten this concept that they can put back into play the non-PPACA compliant insurance plans, and that's okay, at least until 2016. I really don't know what is okay. I mean, I don't know if you have lifetime limits, do you allow them now? I don't know where this non-compliant aspect draws the line as to what you've got to have, that you can be non-compliant, but you got to have this, because no one's ever talked about it. Mm-hmm. And in real life, having a plan that was already canceled, suddenly reinstated, is not an easy thing to do within the insurance industries, because these plans were not submitted through the insurance commissioners. I know that in Oklahoma, Commissioner Doak said that he was going to allow them to do it. I cannot, for the life of me, put my hands around what it really means and how they're being in play. But that's out there. So we've got the exchange plans, the non-compliant insurance plans, and then the self-funded plans.
There you go.
Now, the self-funded plans, you want to go over the next, yeah, there we go. The purpose of going through this discussion is to make sure that you understand how it fits into the scheme. Self-funded plans have to have certain things in them, those two boxes. We talked about minimum essential coverage, minimum value, and affordability. Self-funded plans have to meet those things in order to avoid the penalties that an employer will face if they don't. And the penalties we've talked about before are the pay or play penalties. There's two elements of it. The first part of it, well, let me do a caveat. They are not in play in 2014. None of the pay or play taxes are in play in 2014. They have been delayed until 2015, for some employers until 2016. But nothing is in play for 2014, so you will not be subjected to these penalties for 2014, even if you don't have the affordable cost for an employee. They're just not in play. This was part of what came out at the very end of the year because of the reporting information gathering system that has to be in place in order to enforce this. And I think the IRS and HHS and DOL finally realized they didn't have a mechanism in place that was going to allow them to do this. So with that being said, I want to make sure that you realize 2014, none of the pay or play penalties apply. In 2015, there will be the penalties will apply to some employers. In 2016, they will apply to all employers. And the pay or play taxes have basically two components. The first part of it is what we call the sledgehammer, and that is where an employer says, I'm not going to offer coverage. And the easiest, simplest way is, I'm out of it, I'm not going to do it, I'll just pay. So what happens is, if you are an employer that has full-time employees and full-time equivalents, and you have more than 50 of them, you will be subject to the pay or play rules. Sometimes you'll hear it called as the 49H taxes. 49H refers to the section of the Internal Revenue Code where this tax is actually in place. 50 is the drawing line. Now, you have to make sure that you're understanding that 50 means 50 full-time employees plus full-time equivalents. The easiest way to give you an example is if you had 45 employees that are all working 40 hours, or I guess in this world today they only work 30, and then you have 10 employees that work 20. Those 10 employees that work 20 hours each, when you add them up and divide them by the 30, are going to give you probably 6.6666, let's just call it 7, full-time equivalents. So when you add them to your real full-time employees and add that equivalency, if you're over 50, you will be subject to the rules. Now, for you guys, it's real important that you understand that when you're making these determinations, you're looking at a control group of employers. You're not looking at individual companies if there is common ownership between the companies. And that's real important for people to understand at this stage so that you understand whether you're over the 50 or not. The control group rules, which are IRS rules that have been around for a long, long time, most of you probably are somewhat familiar with them because they're the same rules that apply in the retirement plan arena. So if you have a 401k plan out there and you have done an analysis because you have multiple agencies or multiple companies, then the same result that you got in the retirement plan is going to apply for this in terms of deciding whether you meet that 50 threshold. If you're under 50, it doesn't matter, you wouldn't be subject. If you're over 50, you're in. Once you get that 50, that's the only component you use this concept of full-time and full-time equivalents for. Are you in the penalty or are you not in it at all? If you're over the 50, you're in the penalty.
There is no discussion of having to offer benefits to full-time equivalents, and we get a lot of calls on that even today. So we really wanted to pound that. I think that most of you all are pretty up to speed with that. So the 50 full-time or full-time equivalents is really that initial test to see whether or not the pay or play even applies to you or not. Now, of course, I think most of you all are definitely going to be beyond that, and so it does apply to you. So now you've got to kind of pay attention to how the penalty works. And now you have to, since you're under the pay or play penalties, now you have to pay more attention to the delays and whether or not the delays apply to you or not.
So once you know you're in, because you've got that 50 magic number, then the rest of it is full-time employees. The first part of the penalty, the sledgehammer, is if you don't offer anything, then the penalty to you is you have a $2,000 for each full-time employee. The original law said it's going to be full-time employees minus the first 30 times 2,000. That 2,000 is a non-deductible tax penalty. It is an after-tax penalty. So if you have a plan that does not meet minimum essential coverage, that penalty applies $2,000 times the full-time employees minus the appropriate number. And I say that because it was originally 30, and as you're going to see when we talk about it, that number too has changed. Okay, so the requirement is that you offer minimum essential coverage. Minimum essential coverage is any group health coverage. The only requirement that a minimum essential health coverage has to have is you have to have preventive services covered at 100%. That's it. If you have a plan that has preventive services covered at 100%, you have minimum essential coverage.
Preventative services as defined by the Affordable Care Act.
Preventative services as they define it, yes. So if you have that, that is sufficient to call it minimum essential coverage. And you can see there's a big difference between that and the minimum essential benefits list that had those 10 categories of benefits that had to be covered.
I don't think we have a single, under Kempton Group Administrators, I don't think we have a single client that does not offer a plan that does not meet minimum essential coverage. So
you all have it. Yeah.
You all have it. So that this sledgehammer penalty would not be a concern unless there was somebody out there that was contemplating just completely getting rid of their benefit plan and going without.
Yep. The only criteria that comes with the minimum essential coverage is that you have to offer it. You have to give the employee the opportunity to have the coverage. And most of the plans are doing that by having the open enrollment. Years back, we used to do plans where you get a chance to enroll, and if you didn't enroll, you could never come back in. That isn't an option anymore because now, unless you have open enrollment, you don't offer that opportunity to get the coverage. And that's the whole purpose of the open enrollment period for those that haven't had it in the past. Now,
Talk about the delays.
Yeah, the pay or play penalties are delayed. They don't apply to 2014. For 2015, they don't apply to you if you have between 50 and 100 and 99. If you're 100 and over, they will apply in 2015. So if you're between 50 and 100, you're going to be safe for 2015 because you won't have to deal with the taxes. You will in 2016, and everybody comes back under the fold. If in 2015 you have more than 100 full-time employees, then now you're looking at the penalties applying to you, but they've made some significant concessions in terms of how they will apply. First, you don't have to offer it to all full-time employees like they originally said or like the statute is written. And if you'll remember, when the original statute was the flushed out a little bit, they said, well, we understand we have to have kind of a de minimis kind of threshold. And so they said, it doesn't mean 100, it means 95%. For 2015, it's only 70%. So it's a smaller class that you have to offer it to, which means that for employers that have already made changes to make sure that they put the part-time people and keep them really part-time, or have removed people, or have started adding people that they now offer coverage to, we move too fast because they changed the way that the rules are so that now you only have to have it to 70%, which is good for you because I think for those employers, the likelihood that this penalty is going to apply is going to diminish significantly. The other thing that has changed is they've expanded the classification of people that are not included in terms of seasonal. It's easy to know who the 30-hour work people are. It's not so easy to know when you have people whose hours aren't as fixed. I think before the end of June, we will have something out in writing to everybody that kind of gives the listing of what the new regulations define these people to be so that you can start playing with it and start working with it. 2016, it is expected to be in full operation. There is still a lot of talk about some changes. There's a bill that passed the House to change that 30 hours a week and raise it to 40. It's sitting in the Senate, and Harry Reid will not put it out for a vote. There are people that have been wanting to change the 50 to 100. They've tried passing that. That's a possibility of something that may change so that if you have less than 100, you won't be subjected to it at all. And then there are people that are still talking about eliminating it altogether.
Maybe not eliminating it, but indefinitely postponing pay or play.
or postponing it. And I think once, when we get to the last section of this presentation, we talk about the reporting, you're going to see how difficult it is, because in order to enforce this, the IRS has to have a tremendous amount of information. They have to have a lot of information to be able to get to this. These penalties are applied not really on an annualized basis, they're actually applied on a monthly basis. So the $2,000 penalty is 2,000 divided by 12. And if you didn't do any coverage for 3 months, but then you did coverage, you're subject to the penalty for 3 months, but not the rest of it. And what that tells you is that the IRS has to gather so much information to be able to tell on a month-by-month basis whether any of the penalties are going to apply to employers for an employee. So the sledgehammer is the one where if you really do nothing, you don't offer a plan that even offers preventive services only, and you're more than that 100 next year, that would be in play for you. For many employers, the piece that's really going to kick in is not the sledgehammer, but the next one, which is the tack hammer.
I think we beat this sledgehammer to death, so we'll move on to
Yeah.
the tack hammer. And just on our last presentation, there was a little bit of confusion. The tack hammer and the sledgehammer are both under pay or play. They're both pay or play taxes. And so when things have been delayed, the delays that we outlined for the sledgehammer also apply with the tack hammer, because they are all pay or play is what has been delayed, not just the sledgehammer. So our previous participant had caught that for us. So
What happens in the tack hammer penalty is if you do offer that minimum coverage, the MEC part of it, then you get out of the big penalty, which is $2,000 for all, for each full-time employee, and you move into a penalty phase that is a smaller penalty, not on a per person basis, but in an aggregate basis. This part of the penalty, the tack hammer penalty, applies when you did offer coverage, but you offer it and you didn't meet the minimum value or you didn't meet the affordability component. But it only applies if that individual actually enrolls in the exchange and actually gets a subsidy. If they enroll in the exchange and they don't get a subsidy, it has no impact on you. But if they do get a subsidy, then the IRS is going to look at it as this is a person that you did not offer, you offered coverage, but you didn't offer them minimum value affordable coverage, and therefore you're subject to a penalty on that person only, not all of your full-time employees, just that one. So it is a way, really, when you're looking at the tack hammer penalty from a business point of view, there may be times where you're willing to just say, fine, I'll take the tack hammer penalty on this group of people that I'm not going to do the coverage for.
I'll take the risk on the tack hammer.
I'll take the risk on it because I won't have to pay it unless they actually go on the exchange, sign up for coverage and stay on it and qualify for the subsidies. Otherwise, you're off the hook. And so some employers are willing to work with this provision of the penalties a little bit better. This one is $3,000 for each full-time employee, or $250 a month. But again, it's only for those people that actually go on the exchange and get a subsidy. Okay.
Those things have to happen. They have to you have to have not offered coverage that was minimally affordable. Didn't provide minimum value, and so it's kind of you've got to have all four plans have to line up there for you to be able to get to have be subject to the tack hammer penalty.
Yep. In 2016, I told you everybody said everybody that meets that threshold is going to be in it, but for 2015, only the large employers are subject to it. And the two components that are likely to create a tack hammer penalty is if one, you didn't have minimum value, or it wasn't affordable. Minimum value is a term that is a PPACA term that is intended to define the breadth of costing that the plan pays as opposed to the employees paying. And the threshold is set at 60%. So there's this, what I call a mythical calculator. It's a calculator it is an Excel spreadsheet that was created by HHS that you input. You don't get to input your plan data. You answer the questions that they have in terms of what your deductibles are, whether you provide hospital coverage, you provide prescription. You fill in the blanks for them, and it goes in the background and calculates this mythical concept of how much the plan actually pays in terms of total cost. So long as you're over 60%, you meet minimum value. Most of the plans that are the KGA plans are way above 60%.
We don't have any plans that are even approaching the 60% level. I mean, we have some that are in the 90s.
Yeah, the richer the plan, the higher the percentage. But I want to just make sure that you realize that this minimum value is not really defined based on what your plan actually does in reality. It is what your features of the plan are solely in comparison to this mythical calculator and what they include in the calculator. So for example, for those of you that use the Kempton Premier providers, in those situations, the employee doesn't pay anything, the plan pays 100% of that, but the calculator doesn't take things like that into account. It's not a feature that you can build into it.
When you all offered Kempton Premier Provider as an example, that was a significant richening of your plan, of course. However, that this calculator is fill in the blank. It's not essay, and so if they don't ask the question, you have no way of putting that parameter into the calculator. So again, Premier Provider was something that is essentially off calculator. It didn't richen, lower, or so it's not taken into consideration at all. Maria talked about it provides 60% of the cost. It's not really. I mean, that's what they say. It's 60% of the employee's cost. But there's so much more that goes into determining whether a plan is a rich plan or is a less robust plan, and they're just not capturing that information. It really is a mythical, I like your term, mythical. It is a mythical calculation to try to score your plan as it relates to the plans that are offered within the marketplace, within the exchange. And so for your plan to meet this minimum value, and so therefore get the Obamacare seal of approval on it from a minimum value standpoint, it has to be equal to or better than the bronze level plan, which is the lower, it's the base plan that's offered on the exchange. If you offer a plan that is as good or better than that plan, then your plan is deemed to have met minimum value as far as the TAC Hammer test is concerned.
And keep in mind, minimum value has nothing to do with what the cost that you charge your employees is. It has only to do with how much they pay for a deductible, how much they have out of pocket, how much they have in copays. That's it. It has nothing to do with how much money the employee puts into the pot versus how much the employer puts into it. It's just once the money's in the pot, how much is the employee going to pay out of their own independent pocket versus how much is coming out of the plan. So it's really very mythical in its own construction. The second component is, assuming you meet minimum value, which most of your plans actually do, then the last component would be the affordability. Is it affordable? So you've offered minimum coverage, you've offered it because you got open enrollment, you offered it to all these people, you've passed the first threshold, you're in the second threshold and said, did it meet minimum value? Yes. Was it affordable? Affordability is one of those things that it's kind of, if they drafted a law that had reasoning to it and had been negotiated in a conference committee, I think they would have cleaned this up significantly. As it stands, affordability is defined based on whether or not the cost of individual only, not family coverage, but employee only coverage, is less than 9.5% of household income. Well, you don't have household income in your books, and most employers are not going to pay by the statutory definition. You just can't play with that. It doesn't work unless you wanted to collect tax returns from all your employees, which I would encourage you not to do. So what you do is you look at it more from the safe harbor that the IRS provided. And the safe harbor that the IRS provided is to say, if the cost, your lowest cost plan to the employee for single only coverage is less than 9.5% of their taxable compensation, it's affordable. And I caution you to understand that taxable does not mean gross compensation, because if you have, your employees are paying the cost they put into the cost sharing for the purchasing the plan on a pre-tax basis, they have dependent care benefits on a pre-tax basis, they have 401k contributions on a pre-tax basis, all of those items are excluded from the taxable compensation, which is box 1 of the W-2. So it's only those monies that are going to be subject to federal income tax after the items that are deducted through normal employer plans. To me, that's kind of a crazy way to do it, because it doesn't make sense, but that is the way that they defined it. And to just kind of give you a sense of how that plays out, if you had a minimum wage employee, that's basically $89 a month as 9.5%. So, when you're looking at what you're doing in evaluating whether your costing to the employee is affordable, you're looking at trying to stay probably within that 9.5% of the employee's taxable wages. I know when I've worked with some employers looking at it, one way to analyze it is go look at your lowest paid employees, and I'm talking full-time employees only, okay? Because these are the only ones that are subject to these that are going to subject you to the taxes. So, on the full-time employees, if you take a look at your lowest paid employee and you look at what 9.5% of the lowest paid employee cost is for the lowest cost single-only plan, if you're charging them less than that 9.5%, odds are all of your plans are going to be affordable. Because it doesn't matter whether the second or third plan is affordable, it's only the lowest cost and single-only coverage.
Some of you all have added or will be adding, we've called it a bronze level plan or a minimum value plan. For those of you all that offer an array of benefit options, you may have added recently a plan that if most of your plans meet that minimum value requirement at 85-90%, then there is a cost associated with making that affordable to the employer. You're going to have to make sure it's not more than 9.5% of the taxable wages. Now, if you were to offer another plan that is of lower cost to the employer, one that maybe meets the minimum value standard at 62-63% of the calculator, then that is a lower threshold for the employer to make sure that that plan is affordable. Because you don't have to assure that all of your plans that you offer are affordable, just that a plan that at least meets minimum value is also affordable. So that would be your lowest cost plan.
And on these penalties, it's real important for employers to understand that it doesn't matter whether an employee says no thank you to you. Your obligation is solely to offer them the coverage. Make sure that it meets minimum value, make sure that it's affordable, and if they turn you down, you are out of the penalty provision. They may be in penalty provision, they may get subsidies on the exchange for other reasons, but as an employer, they will not subject you to the penalties under the pay or play.
Yeah. So let's just recap that real quick before we move on. Back. I just flipped the slide back over to the sledgehammer. So let's say that you were an employer that wanted to just, what would it look like, Jay, to completely stay out of the penalty box for this, if that was the approach that you wanted to take? Then you would be offering a plan that meets minimum essential coverage, that provides minimum essential coverage, which, again, we've already said all Kempton Group Administrator plans do that, so we can check that box off. Now, that was for the sledgehammer penalty. The tack hammer, to make sure that we're out of the penalty box from the tack hammer, long day. We have to offer a plan that at least meets the minimum value. So if you, again, I think majority, if not all of the plans do offer, employers offer a plan that meets minimum value. And then it'll be up to you all to determine whether or not that plan is also affordable. Let's assume that that lowest cost plan is also affordable as defined by the ACA. So you've been able to check all those boxes. At that point, the employer is firewalled. That was a new term that we learned in DC. I don't know whether you're going to find that in any regs or not, but it did come out of an IRS agent's mouth that the employer is firewalled for those employees if they're able to check all of those boxes. In other words, it doesn't matter if Sally Sue decides you're doing all these things, but Sally Sue says, I'm not going to take my employer's plan. I'm going to go off to the exchange. And even if Sally Sue goes to the exchange and gets a subsidy, then you are still, as an employer, you are not in any kind of a penalty mode, because it doesn't matter what Sally Sue does. You are firewalled from being penalized. Now, some of you all may say the price tag to be firewalled is a little too high, and so we're going to want to maybe manage this tack hammer risk, and maybe run the risk that maybe a few of our employees maybe are going to go off and get coverage off of through the exchange and give subsidy. And so maybe we're not going to make it affordable. Or maybe we're not going to offer a plan that meets minimum value. We're just going to do a MEC. So in that situation, you are going to be managing your exposure to the tack hammer penalty, and you feel like that is a reasonable risk. We do have employers within Kempton Group administrators that have two different philosophies on that. So if you have any questions in regards to that, you can obviously talk to me, Maria, or your account manager. All right, moving on.
I think in terms of looking at who you offer your plan to or who you're required to offer the benefit plan to, because I think most people that are sitting and listening to this webinar have made a decision to offer health plans for just HR reasons. It is a benefit that employees want. And as the cost of healthcare continues to rise, which I think it will become an even more valuable benefit to offer. So from an HR position, it's going to be very hard.
A big differentiator.
A big differentiator. It'll be hard not to have it. The thing that you want to look at, and this is the part that I think you want to start making sure that you're starting to pay attention and analyzing, what I would call is really understanding your census. Define who your full-time people are. If they work 30 hours or more, they're full-time. I mean, that's all you need to do. They're going to be included in your numbers. If you don't know that they really worked at least 30 or more hours, then they're called the variable employees. And on those, you have different alternatives in terms of how you apply the rules for them. I am not a fan of the original safe harbor that the IRS put out there. That was a fairly convoluted process for doing a look-back period, a stability period, administration period, and then it's a crazy thing that they defined. I think they realized that it was really, really unworkable, and what they came back with this round of last changes, which was within the last 3-4 weeks, is this concept of just looking on a monthly basis. From an employer point of view, I think some of this information is already available to you through your payroll systems. If you're not sure you're getting it, I think this is a good time to start looking through your payroll company, find out what reports are available to you that can help you identify individuals that are working less than 130 hours a week, and you can start monitoring those that might really be variable, and monitoring those that shift out of being a non-full-time into suddenly having positions that are full-time. It can be used in one of two ways. One is to manage them so that you keep them under the 30 hours, or to manage them saying, okay, you're really busting this average 30 hours a week number, so I think you're really full-time. Let's get you offered, let's get the coverage up to you and get it offered so that you start moving away from having a penalty for that person. As I said, I will be putting something together that's going to give, I think, all of you KJA people a little bit more information on what this variable stuff means, because it's not completely well defined, but it is better defined than it used to be. And there are some provisions in there that now have this seasonal that is a much better definition than what we started with, and this variable concept a little bit better defined than where we originally started. And I think that will be helpful. But truthfully, every employer has their own little way of practicing their world. Your world is different from each of you. And whether you use seasonal employees or really use a lot of part-time employees, you know where you are. So monitoring this information through your payroll system to understand where your employee base is and how they are categorized, either as all full-time guaranteed or not so full-time, is important for you to start doing that, because as we talk on the next phase, the reporting that is going to come into play is going to require you to have this information reported to the IRS.
We have been talking to, in addition to that, we've been talking to a number of vendors. Obviously, we're getting our door knocked on a weekly, monthly basis from different vendors, different solution providers that want to assist our clients with their variable hour employees and their tracking. This thing is still in flux, as Maria just said. We feel that the correct place for this type of tracking functionality is at the payroll vendor. The payroll, if you're outsourcing your payroll to a Paycom or an ADP, we know that those folks are developing offerings to assist in this kind of tracking and reporting. If you're an employer that does payroll in-house with a payroll system, software system. Now is not the time to hit the panic button, but now is the time to be asking those vendors, how are you going to help us with our variable hour tracking? What are you all developing out there? We're going to talk about reporting here in the next slide, and it kind of all rolls up the same deal. On some of the reporting, there's going to be areas in which the Kempton Group is going to be integrating with certain payroll vendors because there's pieces of the puzzle that we have, pieces of the puzzle that they have, and we're going to be working with them to put the two together. But honestly, I would hate for any client to go out and buy some sort of a standalone, unintegrated tracking solution just to find out that in 6 months, your payroll vendor comes out with a solution that's kind of a one-stop shop for this. When we look at this, we talked about designing something in-house for us to offer. And honestly, it is the place that this needs to be at is at the payroll department. It needs to be at the payroll vendor or at the software side. It'll just end up being another functionality of your payroll.
That information is there, especially when you're looking at your variable people, because more often than not, those people are paid on an hourly basis. So there is some accumulator out there for their actual hours worked.
Yep.
Yeah.
Okay.
I want to talk a little bit about some of these strategies that people are using and just kind of give you a heads up as to some work, some don't work.
Some good strategies, some definitely don't want to do strategies.
I haven't seen an employer yet that just says, I'm not going to offer anything at all. So most of them are really working to minimize the pay or play, or to minimize the cost of the plan and the people that they offer, the belly buttons, as I call them. The first thing that's out there is that skinny minimum essential coverage, the MEC plans, and those truly are preventive, PACA defined preventive services only. And if you had a plan that did that only, that is minimum essential coverage. It will not meet minimum essential value. So it will put you into the second component of the tax penalty for the pay or play, the sledgehammer.
You almost said tax hammer.
I almost said that. I was going to say that the taxable assessment. In D.C. a couple of weeks ago, the IRS referred to the taxes under the pay or play provisions of the Internal Revenue Code as an assessable penalty, an assessable amount.
Assessable amount.
And I was like, what? So some employers are using that real skinny minimum essential coverage only. It really is used to control and minimize your total liability in terms of the pay or play penalty by using the sledgehammer provision and not the tack hammer. They are not for everybody.
Avoiding the sledgehammer.
And using the tack hammer.
Yeah.
Being under the 3,000.
Managing the tack hammer.
Yeah. Where you pay only if they actually go on the exchange and get subsidized, not for all your full-time employees. Some employers are starting to look at excluding spouses to reduce costs, offering it to dependents and employees, but not to spouses. I don't know how well that's going to play in the marketplace. I have seen a trend towards charging spouses more when they have coverage available to them through employment, and changing what they will have as a required cost for that spouse. But not too many are flat out excluding the spouses. I don't know that plays very well in an HR world. The other thing people are doing is really managing employee time. They're keeping the part-time as part-time, and they're under 30 hours, no ifs, ands, or buts. Once they're under that level, there's no required coverage. You've seen in the media some of the companies that did it. I think Federal Express, UPS did that, where they're just containing the number of hours that people can work. And once they get close to that 30, you're off the job. That works for some arenas. It doesn't work for every employer. And I think it's something that you'd want to look at your actual industry and how you operate to define whether or not that's a workable thing. It might be workable for some pieces of it, but not all of it. But you got to know your senses to really understand whether that's an option for you. The creative one that came out was just saying, fine, I'll just, don't take my health coverage. I'll just pay you for the individual coverage. So you offered something that was a MEC, but then you paid for them. Well,
you paid for them to go on the exchange.
You paid for them, yeah. You paid for the coverage. That's kind of been interesting. That I'm not even sure that the IRS has released this. They issue this information and frequently ask questions. And the last one that I saw that addressed that said, well, if you're paying for the coverage, that's going to be considered a health plan.
That was actually a response to a questionnaire from the SPBA, from
To
the
the IRS.
Society of Professional Benefits Administrators, to the IRS, and they just responded this week with the answer that Maria's going to share with you.
Yeah.
So this is not out for.
I don't
this
think
is not
it's
in
out
the
yet.
general population yet.
That their approach to it was, it is a health plan, which is really kind of interesting, but it's a non-compliant health plan. And non-compliant health plans are real scary because they will put you out of business. Basically, their view of it is if you are a non-compliant health plan because you have a limitation on the dollar amount that you pay. So therefore, it's a plan that has an annual limit that is impermissible, and that then costs $100 per employee per day. So they said that's $100 times 365 days, so that's $365,000 per employee.
Per year.
Unworkable. So that people were thinking that was a good way out. Like I said, this stuff is changing.
So the fourth one down is not a recommendation.
Definitely stay away from that.
Yes.
But that's the creative thinking that's taking place. 2015 is going to be an interesting year. Two things to tell you: if you're over 200 employees, the automatic enrollment was delayed until 2015. So in 2015, that will kick in, and sometime in the fall of 2014, we've got to make sure that you guys have systems in place so that you're offering the coverage, and if they're not responding, I mean, that there's something in place to create that automatic enrollment feature if that's what you need to have. And the second thing is the exchanges. This year is kind of a partial year. I don't know that the insurance carriers are really going to have great information to base their actual costing for 2015, but they are in the process now of designing the plans and looking at the cost of those plans, because they all have to go through state insurance departments to get approved. And so that's starting. Unfortunately, no one's going to know what it's really going to cost until after the elections in 2015, because the exchanges, after 2014, because the exchanges will not have open enrollment until mid-November. That's going to be after the fact. It'll be interesting to see. I think the costs will go up. I don't know if any of you have ever gone on the exchange and looked at what's out there. They tend to be high deductible, high out-of-pocket, expensive plans, and they're
experiencing serious adverse selection.
They have to go up. Their adverse selection is high. I think the initial information coming out is that the adverse selection is a little bit higher than they were anticipating, which is not surprising. But I think it's going to force people to really think about what the cost of healthcare really is, not the premium cost, the real cost. When from your employer's chair, the real dollars that come out of your coffers to pay for the benefit. That no one's focused on those numbers in the Obamacare law, and I think it's going to have to start happening in 2015.
Kempton Group Administrators' clients are.
But I mean, Obamacare law.
Agreed.
Yeah, you guys pay attention, but the law is not designed to pay attention to what the cost is. They don't have a clue.
That's true. That's true.
The last element, and I want to make sure that I tie this into where we started. We looked at the ACA changes. We looked at the taxes and the penalties that are going to apply to the individual, the employers, and the plans. And so this aspect of it is looking at the reporting. When the pay or play penalties were delayed for 2014, they did so, they said, because this part of it was not fully implemented and it wasn't developed enough to really roll it out. And so that's why the whole thing got delayed until at least 2015 for some employers and 2016 for others. But there's basically two elements to it. If you're going to have the system where everybody's going to be accountable and everybody has to be in the game and play at an individual level, they either get coverage or they pay a mandate. At the employer level, they either offer coverage or they're going to be subject to penalties. The reporting is where it's all going to tie together. This is where they're gathering the facts to be able to enforce those provisions. 6055 is the section of the Internal Revenue Code that is a report that is going to be given to employees. And I equate it kind of as a W-2. except that the W-2 in this case is going to be a statement that is going to tell the employee whether they had coverage and for what months they had coverage, and if they have dependents or spouses covered, whether the dependents and spouses were covered.
This is that proof that they had coverage
This is the proof that they had coverage.
for the individual.
The individual is going to be responsible for maintaining that proof so that when they file their 1040 on their tax return, when they get, as the IRS agent in Washington said, when we call you to say, show me the proof, that you take out this piece of paper and say, see, here it is. And when they call your child who filed a separate return and the child says, I don't have a clue, they have to go to mom or dad and say, here it is, because that's the only place it's going to go. The employer is going to be obligated to provide it to the employee. The employer does not have an obligation to provide the notice to the spouse or to the dependents. The notice to the employee will include whether the spouse or dependents are covered, but you don't have to provide separate notices to each covered person. The form for that is not yet available, so I don't know exactly what format it's going to have. I don't know exactly how it's going to be worded or how it's going to play out. I can tell you that they are expecting the employers to file it, and this is every employer that has 50 or more full-time and full-time equivalent. They're expecting every employer to file it for the 2015 year. Even if you're not subject to the penalty, you will be expected to comply with the reporting requirements, and the 6055 notice will be given to employees at the same time frame as the W-2, which means you got to give it to them during the month of January, and then there'll be a transmittal to the IRS that is going to be either March if you're filing on paper form, or February if you're filing paper, or the end of March if you're doing an electronic filing, and they're clarifying how those rules are going to work. And so I don't have any real information on that. I think this is going to be a subject of a future webinar to give you some more information when it comes in. The second reporting aspect is the one that's going to be the documentation for the employer to demonstrate that it's not subject to the 4980H rules. I've taken the argument, or I've made the argument unsuccessfully to too many people, that if the rule doesn't apply to you in 2015, the reporting shouldn't apply to you either. The IRS seems to think that they can waive one component of the statute but enforce the other. So every employer that meets that 50 threshold is going to be filing some type of a report with the IRS in January or February of 2016, reporting the 2015 coverage. And the scope of the information that is going to be on there is pretty expansive, because it's going to require you to report employees on a monthly basis and report the coverage, that whether you offered what minimum, whether it was minimum value and what the cost was, so that they can determine whether it was affordable. Conceptually, this is the stuff that's going to go in the black box, and then it's going to be shared with the Department of Labor and HHS and the exchanges, and they're going to gather all this information to go back and say, employer, Mary Sue over here didn't get affordable coverage offered by you, you're subject to a penalty. The forms that they're using for this, they have names, but they don't exist. And the IRS doesn't have them all in place yet. I think they're trying to kind of coordinate the reporting so that you file a report and do it one time and it satisfies everything. I think it's going to be a very complicated report, and that's why they don't have the form out yet. And I don't know that they're going to have it out the end of this year, because you don't have to file it until 2016. So they may be middle of next year before we really see the guts of these forms to really understand how you're supposed to accumulate this data.
And as Maria said, there will be a future webinar on 6055 and 6056. Also, for 6055, since there is no form right now, it's kind of hard to get a handle on this. But at the Kempton Group, we feel like a majority of the information that's going to be required on 6055, we may have access to it. We may have it within our system. And if that is the case, and we are able to produce this reporting, either maybe not actually filing the form, but being able to provide the data on a sheet of paper that has all the appropriate fields in place, and provide that to the employer, we are going to make an attempt at, this is something that I envision that we would be providing, or at least greatly assisting our employers with meeting their reporting requirements for 6055. And I hope I put enough caveats into that, since we don't have a form yet. But that will probably be a function that we'll be offering as a service to our employers. Now, 6056, Kempton will not be able to do the filing or provide you with all the information that's going to be required for 6056, because there's a part of the puzzle that we just don't have. The part about that has to do with the payroll and whether or not the coverage that was offered, A, was it offered, B, was it affordable at the time it was offered, that's going to be something that we're not going to have access to. And so we'll have access to part of it for 6056, but most likely your payroll department or your payroll vendor will have the other piece of the pie. And so we envision, and this is just development off the cuff here, but it is possible that we would be able to integrate with select payroll software vendors and also select outsourced payroll vendors to either provide them with the data that they don't have so they can do the reporting for you, or some other type of an arrangement like that. But we are talking with Paycom and ADP potentially for that 6056 reporting, being able to transfer data back and forth with them. If you have, as a client of ours, if you all have a software package that is that you do your payroll in-house on, like we had said on the pay or play tracking, when I said, ask them the question about, are you going to be developing some solutions that can help us with our pay or play tracking? This is another thing. Are you developing a solution that will assist us with our 6056 reporting? If they say, I don't know what you're talking about, then that should be concerning. If you're doing it in-house with that vendor, you may ask them, if you're going to be developing a module for 6056, is there some sort of a inload specification where you can take data from our health plan administrator? If they say, yeah, we do, we'll send it to you. We would love for you to share that with us, and so we can be a good partner to you all to provide the piece of the puzzle that the payroll company will not have. So again, there will be, don't sweat it right now, there will be another webinar just on 6055 and 6056 in the future, hopefully after we actually get the form and we have a better feel for this.
Yeah, this is an evolving area, absolutely evolving.
Yep. Now, of course, we've also had vendors knocking down our doors telling us that they have this all figured out. And as Maria asks them some of her pointed questions, we find out that no, they have the marketing sheet all figured out, but they actually don't have the product all figured out yet. But there are folks out telling you that they have solutions to this. If they're telling you they have it all figured out, they're not being truthful with you, because until they actually have the form, there's no way that they can completely flesh this product offering out.
And just as a tidbit of things that I know will be coming, Oklahoma has a couple of things out there. Number one is the Hobby Lobby case. And, when I showed you the earlier example where people were wanting to just pay for the premium, and the IRS has said that's $100 per day per employee, $365,000 per employee per year. That's what Hobby Lobby is really fighting. Their whole case is on the provision not of the contraception mandate per se, it's the provision of all contraceptives. They actually do provide birth control stuff. They just want to exclude specific items of birth control, which under the Obamacare preventive procedures are in theory supposed to be paid at 100%. So the regulators are taking the position that if they don't offer all of the birth control options that are available, then they are a non-compliant plan, and therefore that exposes them to the $100 per day per employee penalty. The Supreme Court heard arguments, I think early last month. They probably will not issue an opinion until the last week in June. They shut down June 30th to go on summer break, and I would not expect that their decision will be out until the last week of June, as late as they can get it out there, and they'll get out of town. There's a big gap left in different things. The second bullet item is there are 36 states that did not expand Medicaid. There is a gap of individuals that do not qualify for the exchanges because they're under 100%, but they don't qualify for the expanded Medicaid because it's not offered. And there's going to be some issues with those people because that still leaves a large percentage of the uninsured that were targeted to be included, not offered coverage. I don't know that Congress has a solution for that. That provision of Medicaid, the forced expansion of it, is the only provision that the Supreme Court said was not constitutional when it ruled on Obamacare 2 years ago. And it's starting to rear its head.
Yeah.
The third thing I just want to mention to you is Oklahoma has had a case for a long time that was filed about the same time that the other cases challenging Obamacare were filed 2 years ago or 3 years ago. But the Pruitt case is a little bit different because our Attorney General has taken the position that Oklahoma employers should not be subject to the pay or play penalties when an individual goes on the exchange and gets a subsidy, because the statute by its terms, the black and white part of it, says that these subsidies are available under state-sponsored exchanges, and we have 37 states that are doing federally sponsored exchanges, and a couple more joining because they shut down their individual state-sponsored exchanges. And his position is the statute says state-sponsored, not any exchange, but state-sponsored exchanges. Therefore, if somebody goes on the exchange and gets a subsidy or one of these extra bits of money, they can't subject the employer to these taxes. And it actually is presenting its case as an employer, which is kind of an interesting way to do it. There's a case that came out of the District of Columbia where they've had a very similar argument, and the District of Columbia court turned it down. I think this is one that is probably going to go to the Supreme Court at some point. The Oklahoma case is moving very slowly, but I would expect to see something on it in the near future, especially as the penalties actually start kicking in. It's out there, and it's one of those that's just kind of keep your eye on it.
Okay, we're about 7 minutes behind, which is better than this morning because we were about 20 minutes behind. Apologize for that. We would like to open it up to questions. Have one coming in here. Let's see here. Will Kempton prompt us regarding when taxes need to be filed?
Yes, I'm waiting to see when the 720, which is the IRS form, kicks in with the changes, and as soon as that comes out, there will be a memo. If it doesn't come out, you will get a memo similar to the one that went out last year that showed you what the form is, how to fill it in, and how to compute the numbers. And then we'll give you, I think Kempton has a means of calculating an estimated number of participants or belly buttons to use for the count. On the that's for the PCORI tax. On the reinsurance tax, that is going to be handled in a very awkward way in that a report is going to be filed with HHS. I think Kempton, as soon as they issue the procedure as to how it's going to be done, I think Kempton will be in a position to do a lot of that, where they can notify HHS of the number of belly buttons in your plan. HHS will then send a bill to the plan. We're trying to work through, what makes sense. I'm suggesting that the bill probably be sent directly to Kempton so that it gets processed through your plan payments as opposed to getting lost somewhere in your internal accounting systems. And then when the payment is due, which part of it will be due in January and part of it will be due later in the next year, that they will then generate a check and say, here is your reinsurance tax amount, and you will know what it is in advance, but you will get information on both of those in advance of the payment being due or having to be paid.
We're actually turning both of those those tax filing duties over to the Kempton Group accounting department, where the two CPAs live. That they'll be working close with Maria to make sure that the appropriate memos go out and that those get all handled on time as they should be. You're welcome. I had to thank you for the presentation. Appreciate y'all. Okay, well, we've either got everybody asleep or questions have come to an end, so we're going to go ahead and close the webinar. We really appreciate, we had a majority of the folks stayed on to the bitter end, and so we appreciate that very much. We will be seeing seeing you all as the year progresses, pre-renewal, and if anybody has ever a need for any educational meetings, employee meetings, to kind of further our initiatives with employee consumerism or whatever, please feel free to contact your account manager. Actually, we have an account manager out right now today doing that very thing, and so it's something that we want to continue doing that throughout the year. Looks like we have one more question here. How do we download the slides? Those slides, are they currently
The slides are available on the KemptonGroup.com website, right on the front page where you registered.
Okay. If you didn't hear that, they're available at KemptonGroup.com on the front page right underneath where you registered for this webinar. They'll also be, after they get moved off of the front page in a few weeks, they'll always be under the resources tab at KemptonGroup.com. All right, if that's all, we'll go ahead and let you guys get back to your busy week. Thank you all very much again.